pleasure to spend time with you guys today. And we're going to talk about, I think, a topic that is important and also profoundly confusing. And so what I'd like to do is suggest that we can navigate provider quality in a far more effective way as we pursue greater value. And it's a pleasure to be associated with Gloria and the Employer Forum of Indiana. The work that is being done here is groundbreaking, and I want to let you know that we are going to continue to lean in here in a powerful way to connect information in the hands of consumers and plan sponsors so that they can achieve greater value in their plan spend. So today what we're going to do is we're going to start with a level set. And then we're going to talk about variation in value. And then we're going to talk about how in the heck do you measure quality. And then I'm just going to do a very small study that will explain, I think in real information, the concepts that we're going to review in our 45 minutes. And then we're going to wrap it up. And then you guys are going to be kicked out to move on to the next thing. So let's talk about a level set. And here's what I'd like to suggest to you. So Michael Porter and Elizabeth Teesberg wrote a book called Redefining Healthcare 14 years ago. There are a couple concepts in this book that I think are foundational. And so one of the things that they talk about is this notion of the failure of competition in healthcare. And so really the concepts are competition is too broad, too narrow, and too local. And that this stifles the ability for us to get to the optimal value at the point in time that we need it. And so how's it too broad? Well, you see that we've got broad service lines, not individual services. We've got breadth in the fact that when I, as a patient, hit the door of any provider, I have a huge range of services that are under contract, and that the carriers or the TPAs or others contract at the enterprise level, which inhibits my ability to kind of piece together optimal value at any point in time in my healthcare journey. At the same time, it's too narrow. So we focus on visits or encounters. We don't focus on a full cycle of care. We don't measure value over an entire care cycle. What did it take for me from the time that I had a healthcare problem to the time that that problem was resolved? What was the cost of those encounters? What was the outcome of those encounters? Did I achieve my cost of living? Did this fit within my cost of living? Did I achieve the outcomes that were desirable? And then a lot of people don't realize that physicians, in many respects, are free agents. So we've got independent physicians in some instances that are performing services, and the billing is facilitated by the relationship that they have with the facility, whether it's a hospital, outpatient center, or an ASC. And then what's too local mean? It means that this adage that healthcare is always local means that we're confined to these self-contained institutions that are interested in kind of meeting our local needs, and they don't want us to go out of market. They don't want us to necessarily find care outside of geography that I may live and work in. That the ownership, that the regulations, that the reimbursement kind of institutionalize this bias. And the reality is that many of the providers that we're interacting with don't necessarily offer the volume and experience and outcomes that would be best for us as consumers. And best is not just lowest cost, but we're talking about best reliability or highest level of quality that we could achieve. And so what I'd like to suggest to you is that we can reform the nature of competition, but it begins with the plan sponsor and the member at the point of decision. And so current competition in many respects is zero sum, which means that the people that win come at the expense of people that are losing. Well, this goes against the nature of value-based competition, where you can actually have many people winning in different areas because they're being rewarded for their skill and expertise in a particular clinical area. So what does zero-sum competition do? Well, first of all, it shifts costs. So the participants that are providing healthcare want to lower their costs by shifting costs to other providers because it puts them at a competitive advantage. They want to increase their volume and market share in their bargaining power because they want to capture more revenue, as we said, push costs to others, give a deeper discount, which gives the appearance of greater value. But really what it does is it creates oligopolies that makes it harder for us to navigate outside of. The health plans want to capture patients and restrict choice. Well, what does that mean? So when I get a member in a health plan product or in a particular deliverable, then I'm confined to that deliverable as making my choices. So if I agree on a network or a narrow network, for example, for the next year, I've confined myself in making my decisions restricted to the product or the plan choice that I selected at open enrollment. I don't have unfettered access to any provider that may deliver greater value. And so finally, costs are reduced by restricting services. Now, that may seem counterintuitive, and what Porter and Teesberg were talking about was that access and rationing, when we think about rationing, the fact that we don't necessarily have access to all the services that may be available, we only have access to those services that are able to be delivered in my market area or in the context of my health plan, means that we're using pre-certs and authorizations and other tools to restrict the full choice that I may have access to. And that the way that reimbursement works today with providers also means that they may not be able to get access to the right types of treatments or the right types of tools to treat my clinical condition. And then finally, vertical integration ultimately leads to a lack of choice and reducing costs by restricting services. And we saw this when the HMOs came into vogue in the early 90s. So what does value-based competition look like? So the first thing is we compete based on results. So what can be simpler than I want a patient outcome per unit of cost at a clinically specific area? So is it diabetes? Is it heart failure? Is it joint replacement? Is it elbow surgery? Is it carpal tunnel surgery? What was the outcome or outcomes? What was the unit of cost? And what was the condition? So those three things are kind of foundational to value-based competition. Providers, plans, and suppliers achieve excellence, they perform, and as a result of that, they get more business. So volume and revenue flows to the organizations that are able to deliver the outcomes per unit of cost for a particular medical condition that's more attractive than others. Those who fail to demonstrate good results decline and cease to provide the service. This is an area that I think is profoundly troubling to many people, but yet is prolific in other industries, in other industry segments. The reality is that those that fail to continually deliver greater value or can achieve greater value at lower costs ultimately fail in their market segment, and they are usurped by those that are able to deliver those, or they're consolidated. They may have some technology or some amenity that somebody might want. And the challenge here is that if you think about consumer-driven healthcare and the central tenets, what we largely know is that consumers are not equipped, and I'll present some information which would affirm this, to make decisions in the current healthcare ecosystem. And given the fragmentation of healthcare from the consumer's perspective, again, there's been consolidation and vertical integration from the provider and from the carrier's perspective, but from the plan sponsor's perspective, there's been considerable fragmentation in the delivery of those services. The uninvolved consumers benefit irrespective of whether they are knowledgeable or not about what consumer-directed healthcare looks like. And then finally, And I think probably one of the most important points is competing on results means you've got to have results to compare. And these results have to be provided to the various stakeholders so that everybody can be equally informed. That's not happened. We have members that have no idea about the quality and cost of services provided. We have physicians making referrals to their colleagues that have no idea the reliability of their quality, nor the cost of the therapies and services that are going to be provided. The hospitals can't simply convey what the cost of said services would be to a plan sponsor, to a consumer, to a family member. And so we're left to make decisions in an uninformed, illiterate manner. And so these are the attributes of value-based competition that I suspect are achievable if we work together in a multi-stakeholder approach. These simply embody the principles that we talked about previously. Some key attributes of this is that competition is based on results. It's not based on market share. It's not based on brand identity. It's not based on brand equity. It's not based on reputation. It is simply based on this notion that we can measure results, quality for a unit of cost at a medical condition level. I also think that competition should be regional and national, not just local, because that brings pressure on local providers to perform at levels that go beyond just what a local community might have. An example in my community is we only have really 2 to 3 enterprises of providers to deal with. There should be more than that. And if the complexity of my surgery requires me to take a broader look regionally, I need to be able to look at those results and make more informed decisions. And so Dr. Reinhardt said something that I think is profoundly simple, and that is, if you're a plan sponsor and you want to save money, you have to pay less. You can do that and get more reliable quality, but you can also pay more and get more reliable quality, because the reality is paying less does not always lead to greater quality or reliability of avoidance of adverse events, and paying more doesn't assure that you get access to more reliable quality. So how does variation in value work? So if it's possible for us to be informed, and if it's possible for us to measure results and then to use those results as a way to think about purchasing moving forward, how do we think about variation? Because variation is profound. It is a reality in the healthcare system of a magnitude that is really, frankly, difficult to understand. So Dr. Jack Winberg started studying this variation literally 4 decades ago. And what we find is today that these principles that I'm presenting to you right now still exist. And so unwarranted variation is ubiquitous. It's ever present in the healthcare system. We know that we can remedy those, but there are 3 really kind of profoundly simple things that are barriers to eliminating this variability. So number 1 is, you know what, we've not improved the quality of patient decision-making. The tools that we provide are largely underutilized. People don't know, it's confusing. You're in the midst of a healthcare crisis, and so you rely on trusted advisors or physicians as being people that are more knowledgeable, and many times they're not. So that's number 1. Number 2 is we have no economic incentives that reward exemplary practice. As a matter of fact, many of the most high quality, low cost providers don't necessarily get incented to do that. They found a way to deliver greater value, and we cannot find it or recognize it through incremental market share, you know, greater volume, more incentives, better reimbursement. From the provider's perspective, we've actually created some barriers as plan sponsors that inhibit their ability to deliver better quality. And then the poor state of clinical science just simply suggests that we've got all these different modalities that we don't really know which ones deliver the best outcomes or avoid risk. And we don't have a lot of research that tells us, you know, modality A as compared to modality B is the way that we need to go for this particular patient, for this particular clinical condition. So what does this produce? So this is a map of the United States. Hopefully that'll be self-evident to you. And we're looking at the variation in surgery rates by hospital referral regions for Medicare enrollees. Now, this is information that comes from the Dartmouth Atlas. You can go to the website and look at this yourself. So, from dark green to dark red represents a twofold variation in the prevalence of disease, of surgeries across different disease states. Now, this variability is unrelated to the underlying illness burden of the enrollees in these referral regions. So think about this. So all the variation that you see here is not explained simply by the patient's underlying attributes. It's explained by other things like the prevalence of specialists, regional preferences as to how and when we deliver surgical services, the reimbursement for services with respect to being more attractive than medical modalities. So think about that. Depending upon where you are, the prevalence of surgery can vary significantly, and yet we just presume that everybody is generally doing the same thing geographically. And I can't tell you how many times I'm working with providers that what I've been told is if you share data with providers, that they will always kind of tend to do the right thing. This is information which suggests that we are paying a lot of money as plan sponsors for surgical encounters that may or may not be necessary. Now, if you look at this distribution per 1,000 beneficiaries, each one of these represents a particular market, and what you can see is on the vertical axis, you can see how many of these markets kind of fall within this range of somewhere around 42 to around 100 surgeries per 1,000 beneficiaries. Look at all that variability. That tells us that we don't have clinical consensus on when these interventions might be the most appropriate, the most efficacious, and yield the best results. If you look at this with respect to quality, what you will find is it would be impossible to deliver consistent outcomes with this much variation in the decisions for when a surgery is warranted. And if we look at this across a section of these surgeries, so you've got hip fracture, open and closed choles, hip replacement, CABG, so on and so on, look at the ratio of variation to the national average. It's incredible. And so as consumers and plan sponsors, this notion that there is consistency in healthcare is fundamentally not true. We are encountering healthcare providers that for numerous reasons, I'm not blaming or vilifying them, deliver inconsistent results of inconsistent encounters driven by different criteria, and we have little idea as to how to cut through that and make better decisions to achieve optimal value for plan spend. When you look at the spend per Medicare beneficiary, so in the dark green, it's about $7,300 per year. This is for a few years ago, all the way up to about $13,400. And wouldn't you know that there's a correlation between the prevalence of surgery and the spend per Medicare beneficiary? Now, one of the questions that you might be asking is, well, what does this tell us? If I'm a purchaser, I'm a plan, and I've got a young, able-bodied population, is there a takeaway for me? Because we're talking kind of about Medicare, but we're also talking about Medicare that's clinically adjusted that's illness burden adjusted, so that the variation that you're seeing here is not a product of differences in the underlying needs. You're looking at variation that we encounter within the healthcare system. So do more expensive regions have sicker patients? On average, what we know is, you know what? A fraction of the variability is explained by higher illness burden or an illness level. This is called population based risk adjustment, where you're looking at the propensity to consume services. The variation that we just looked at is not explained by variation in the illness burden of those beneficiaries. Middle one, does Medicare spending track spending on the rest of the healthcare system? And the reality is this, that those hospitals and regions that provide more care to Medicare patients also provide more for their non-Medicare patients. And that simply means that providers tend to practice consistently across multiple payers, meaning that their approach to treatment doesn't vary based on reimbursement. Many times they don't even know what their reimbursement might be. They're filling out bills, they're seeing patients, they're filling out EMRs. They may not be able to tell you what their primary and secondary payer is on a particular patient for the most part. And then finally, does all that spending lead to better outcomes? And here's the reality. There is no relationship between cost and outcome. So what you're spending as a plan sponsor and what your members are spending and they believe is leading to better outcomes is not true. There is no correlation to cost or price in the quality of services delivered. There never has been, and there hasn't been, largely because we've not been able to force that correlation. When you look at what RAND did in the pricing RAND pricing study 2.0 and what will soon be released in the RAND pricing 3.0, what you will continue to find is that there's profound price per unit variability that is being paid by plan sponsors that is unrelated to the quality of services that are delivered. And so as a plan sponsor, if you want to achieve greater value, you're going to have to find ways to connect fair pricing with reliability and outcomes. And the punchline is that as a private payer, you're paying approximately on average 2.4 times what Medicare is paying for the same services, and that the variation is at a procedural level. So it's not just kind of averages of averages. What we're saying is that the variation is profound and it's for like to like. So if you need joint replacement, you're paying sometimes 400% of Medicare in some markets, which is an egregious amount. Now, there are reasons for that we can unpack, but the bottom line is we have utterly allowed price paid to be disconnected from the quality delivered, and we've got to find a way to reconnect those in the way that Michael Porter talks about. One of the things that we did last year was we connected quality and RAND pricing data in Colorado through the Colorado Business Group on Health, and published this as a report through the Colorado Business Group on Health and another organization that represents the interest of consumers. It becomes very important, and what was enlightening was the profound variability that you see in the relative price for inpatient services and outpatient services, and the reliability expressed as a percentile score of the avoidance of adverse events. And there was no correlation to both price and quality in this study. And so what we're left with is this understanding of we've been focusing on what we pay, which is price, but we have no understanding of what the value is that we're receiving. And so the goal in my presentation today is to begin to tie those things together. So one of the things that we've done as plan sponsors is that as we've increased the responsibility of the member to pay for the increasing cost of healthcare, the providers continue to collect less and less. As a matter of fact, for a member obligation of, I think, above somewhere around $250, the collection rate is around 15%. Well, when you think about that, so they now have to go after the member for an increasing portion of the services that have been delivered. It also creates other things like ineffective spend in healthcare, because now we know we have unnecessary services, and some of those services are delivered because we're collecting so poorly as a provider on the services that may have been the most appropriate to deliver. We have administrative costs in billing and collecting, clinical and technical denials. We have inefficient services. We already know that we have prices that are too high, and then we've got fraud and misprevention opportunities. All of those things are things that are paid for by plan sponsors and the federal government, and all contribute to continued inflation in healthcare. So how do we get our hands on, if we want to pull the lever of price, can we also pull the lever on quality to then begin to talk about value and not continue to kind of bifurcate and talk about price and quality as being kind of separate? So in Colorado, there was a survey in 2018 about perceptions of quality from consumers. And what was amazing about this study was, if you look at the bottom, look at the definitions that were selected for healthcare quality. So first of all, number one, how the patients were treated was one of the most commonly selected definitions of healthcare quality. So it wasn't mortality, it wasn't complications, it wasn't did they solve my medical need, it was how was I treated as a person. Secondly, being credentialed. So are they Joint Commission accredited? Are they qualified to participate in Medicare because they've been deemed to be reasonable in their approach to quality assurance? Okay. Are they certified? Or are they credentialed in some fashion? Well, what we know is whether you're credentialed or not has nothing to do with whether you're able to avoid adverse patient events. And then thirdly, how quickly and how well the patient recovered. So none of those were empirical in nature. None of them were, did I have a higher readmission? Did I have a mortality? Did my family member not make it out of the healthcare encounter? And so think about the misalignment of what we just looked at and what you could look at if you wanted to have a more compelling answer to healthcare value. 61% believe that higher quality usually comes at a higher cost, and yet few believe that price reliably signals the quality of care. So what does that mean? It means that they have no idea whether price and quality are connected. We've been taught as consumers that price and quality are always connected. That's why a more expensive car usually means there are higher quality components, a better engine, better amenity, better service. And then 55% that if out-of-pocket costs were about the same, that quality ratings would be the tiebreaker. So quality information is important, but we've not provided information that consumers can feel confident about, can be literate in, and is available at the point in time that they need to make the healthcare decision, whether it's in the midst of a healthcare crisis or it's something that they want to get in front of. Could be something like a routine colonoscopy, an endoscopic procedure, an elective surgery. So members and consumers are largely flying blind. We've got competition that is too broad, too narrow, too local. We've got zero-sum competition, and we've not broken apart these oligopolies that inhibit our ability to achieve greater value. An excellent example, and I love this one. So ProPublica is actually a journalistic organization, and a sales rep for Top Doctors reached out to a reporter and indicated that he'd been selected as a top doctor. So the reporter said, like, I'm not a doctor, I'm a reporter. The rep said, you know what? If you act quickly, we'll take the $300 fee and we'll drop it to 99 bucks and we'll give you an award as a top investigator in New York. But what was conveyed was so utterly ridiculous that this information is being delivered all over the place, and we're not teaching our members and consumers how to shop for healthcare or how to achieve greater value. So let's talk about what matters. Like, does mortality matter? Do complications matter? Do unanticipated readmissions? Do I want to feel safe and receive care that avoids patient safety outcomes that are hugely problematic? And most people are like, don't confuse me with the facts. Like, I want to press the easy button. But here's what I know, as being in the industry for 30 years, that if you were to ask any plan sponsor or any plan member, do these outcomes matter? They would say absolutely. If you were to suggest to them, if you could, would you get cheaper care and sacrifice on any of these outcomes? The vast majority would say absolutely not. If I can't get the best quality care, I will not sacrifice on greater value. So what do? Well, first of all, these are all things that we can measure for. I've been doing this for 30 years, and the analytics that we provide and have been providing are absolutely suitable to deliver to consumers. So first of all, you have to risk adjust that data. And what that means is you have to create apples to apples comparisons. We use binary logistic regression models, and these models are very capable of not disadvantaging or advantaging providers that may treat more complicated or less complicated patients, because what we want is an apples to apples comparison. So risk adjustment and then standardizing data allows us to look at a region. So let's look at something that's very straightforward. And so these are percentile scores for the Indianapolis MSA, so that's the Metropolitan Statistical Area. I've blinded the results. I've taken the hospital names out, but these are hospitals that you would know and that you go to. And on the left-hand side, you see a percentile score, dark green, light green, yellow, and red. So if I have a joint replacement need for either my hip or my knee or my shoulder, and I need that done in the Indianapolis MSA, the way that you interpret these percentile scores is it tells me how reliable that institution is in avoiding mortalities, complications of care, unexpected readmissions, and then patient safety events. Things like a deep vein blood clot or postoperative sepsis, which is blood infection, or postoperative lung collapse, or central line associated bloodstream infection. So I want to go to an institution that's highly reliable. So dark green tells me that they're in the top 10% of providers nationally in avoiding all these adverse events. Lighter green is the top 25%, but not the top 10%. Yellow is the middle 50%, and then red is the lowest 25%, and then dark red is the lowest 10%. So if we weren't to look at any of this information and we were simply to rely on where my providers may direct me or where my hospital was in my city, let's say a local institution, what you can see is that the vast majority of hospitals that are doing joint replacements are either average or below average, that there's only 3 institutions in the immediate area that are in the top 10% nationally. And yet what we've been taught to believe is that many institutions are equally capable at delivering great results. This information would suggest that if you are not informed about your institution's quality performance, that you may very well end up going to an institution that was not as optimal as another institution. Now, if we look at complications of care, look at this. We get a different distribution of hospitals. Why is that? Because they don't all do the same job of avoiding complications of care. And I now have 5 institutions that are in the lowest 25% nationally of avoiding complications of care, meaning that they lag behind where you would expect them to be on a risk-adjusted basis. So if I'm uninformed, I may be putting myself in harm's way. Let's look at readmissions. Same thing. You also see that the list changes in terms of the rank order. That means that institutions, again, are not consistent across the composite score, risk-adjusted complications of care, and then risk-adjusted unanticipated readmissions. And so as consumers and as plan sponsors, it is of utmost importance that we learn to be informed and literate about how do I connect price and quality. Now, let's do something else. So let's take a facility that's highly reliable. So this is one of the institutions in the top 10% nationally. And let's look at an institution that falls in the yellow. So these are individual physicians by their NPI number. So I know they're unique physicians. And what you see here is I only have physicians that are either in the green or in the red. And what you find is even if I go to an institution that is highly reliable at an institutional level, I have to be connected with a surgeon that reflects the same level of reliability. As you can tell, these two institutions have profoundly different volume. The institution on the right has far less volume, and yet I could find a surgeon that delivers comparably consistent avoidance of adverse events with some of the higher volume providers at the institution that falls in the top 10%. So it can't be just at the facility level. I can't just make generalizations. I have to look at the physician and hospital combination. And in this case, if the facilities had, let's say, higher pricing, so we couldn't get a fair price, you could take one of these orthopedic surgeons, and let's say it was a knee replacement that could be done in an outpatient setting or in an ASC, and we would have line of sight into which providers we might want treating low acuity or low risk patients in a more attractive setting from a pricing perspective. And then finally, so here's what we have. So the resulting challenges that we have for consumers and employers are this. So healthcare costs continue to rise. They rise because of the intrinsic variability within and across the providers. They rise because as providers consolidate and as vertical integration continues to progress, choice is denied. We're restricted in where we can go and who we can go to. We see a lot of lack of engagement from employees from the employer's perspective. So we provide tools, sometimes great tools, sometimes not so great tools, and we can't seem to get consumers to be engaged and be sensitive to price and variation in quality. And look at how high employee satisfaction is. So 71% are satisfied with their current provider provided coverage, but there is a concern about the continued escalation. If you look at the Health Research Education Trust and the Kaiser Family Foundation annual survey, what you will find is that the continued escalation in the cost of healthcare is tremendous, and we all know this, and yet we've been largely ineffective at providing ways for consumers to make better decisions. They're not literate, they don't understand, and those advising them, including physicians, advertising, family members, are no more capable of advising us in making good decisions. Part of this is price disparity is unbelievably variable. I mean, and it's not just within a single carrier. Carriers have multiple fee schedules in the same market depending upon the products. You have most favored nation status in some states. We don't know the cost of pharmaceuticals. Physicians don't know the cost of many of the services that they are using to treat us when we're in a healthcare crisis, or even when we have elective surgeries or preventative surgeries. Primary care, as we continue to try to drive enhanced primary care or direct primary care or patient-centered medical homes, are largely uninformed about where value can be achieved optimally. We were working in the Indianapolis market over the last week or so with providers and some broker advisors and direct primary care to begin to set up a plan for how do we help people navigate simply and easily to those providers that can deliver greater value. And then finally, the care variation is unimaginable. The lack of reliability in both the avoidance of adverse events and the types of adverse events that we get exposed to routinely is unimaginable. And so our goal is through transparency, through education, through empowerment, through connecting key stakeholders, we can have an impact for both employers and consumers that help. So how do we do this? Firstly, employers, I think you have an opportunity to purchase healthcare as if it were a service that you would use in the provision of your products. A prime example, Purdue University just made the decision that they're going to do a direct contract with a provider within their region. There's tremendous opportunity for this to expand and to be monitored so that in the form of SLAs or other empirical measurement, you can be sure that the selections that you made last year continue to remain good selections moving forward. Frankly, working with your TPAs or your administrators or finding a way to get to hospitals and physicians to direct contract with or to direct members to becomes essential. You've got to have some kind of a transparency platform. You've got to find a way to make pricing information available and easy to understand to consumers that are largely illiterate about the economics of healthcare. I think engaging with carriers and administrators becomes hugely powerful. Why is that? Because they're not necessarily the enemy. The carriers have delivered what the plan sponsors have asked for. We want the most choice. We want the widest access. Well, what does that do? It can't deliver consistently uniform value. It's impossible. Choice does not equate to quality. We have to have ways to work together to make it easy to find optimal value. I think business coalitions and group purchasing, like what Bob is doing in Denver, becomes hugely important because it galvanizes a group of employers together and gives you guys market power and consolidation that allows you to match the consolidation that's being achieved on the provider side and on the carrier TPA side. Very important. Excellent article from Dr. Blumenthal in 2018 HBR. I would highly recommend that. And then finally, we come back to Dr. Reinhardt, which is simply recognizing that as our incomes continue to be eclipsed, so our rise in wages have been eclipsed, multifold by what it costs to provide health care to our employees and for us as employees to have health care delivered to our families. And we've been largely indifferent about this. We just presume that these increases are going to continue to last. And I agree with Dr. Reinhardt that once people understand that it lies within us to achieve greater value, it's not going to be very long before we begin to break apart these oligopolies and we're able to uncover far greater value and spend our resources and our wages in ways that are wise. And so I would leave you with this thought. Like, we can't just look at this and know, we have to apply this, and I think that is our charge moving forward. And so I thank you for the opportunity to present at the conference. I appreciate the opportunity to talk very briefly about opportunities to create greater value and how quality becomes a vital component of that if it's measured precisely. And I welcome the opportunity to answer questions or to address any comments or anything that might be of interest to you to know or understand more deeply. Gloria, we continue to be interested in leaning in with you guys, as we do with other National Alliance members, to continue to drive towards greater transparency so that we can get to the point of applying these principles. So thank you very much.
Thank you, Shane, for that outstanding presentation and for laying out for everyone a clear path on how we can marry high quality with price. And we look forward to continuing to partner with you as well. So thank you for joining us live, Shane. And if you can take your mute off, that would be great. You're still on me. Oh, there you are. Excellent.
Be muted here.
Yeah. So thank you again for your presentation in our area. So I noticed you didn't share specific provider names, but you do work with certain hospitals and health systems. I was wondering if you could share with everyone really how Quantros, like where the majority of your business lies and what you've been doing for the past 30 years. As I understand it, really this helping employers has been a relatively new opportunity for Quantros.
Yeah, so we've been for the last 20 years, we've worked with providers almost exclusively because they were interested in remediating poor outcomes or reducing variability. And so we began to work with employers when we started working with a small coalition up in North Carolina, and these principles of variation, especially quality variation, became more prevalent, and we got connected with the previous leadership at the National Alliance, and they became intrigued about, frankly, just understanding that cost and quality did not correlate, and that that the National Alliance members needed to be more involved. So since then, we've begun to work with transparency vendors, data aggregation and warehousing companies, brokers, advisors, but we still are very much in an evangelical and educational mode as these principles continue to be conveyed. So it's exciting work. It's also complicated work, as you well know.
Absolutely. So I'm going to share some questions that just came into the chat box. This is actually from someone from a hospital. Is it a concern here that as demand for highest quality grows, will it pull the best providers into larger and larger institutions who will be the only ones who can afford the best? The physician provider shortage is already affecting access. Increasing demand for the very best could increase price / create further access issues by giving the providers so much leverage when given the gold star. Your comments?
So that's a great question. So I think what we're talking about there is, does the healthcare system have enough capacity to move market share towards those providers that offer greater value? Now, remember that the providers are competing not just on quality, but also on price. And when those two things are transparent, what you find is that you have a market that competes on economic principles that we have in other segments. So right now, setting of care is tremendously important. And if I can get a physician to move a procedure from an inpatient to an outpatient setting or a freestanding surgery center, I can save tremendous money on the price and get the same quality with the same procedure list. So we're not finding that it creates another oligopoly. As a matter of fact, Bob Smith is finding that in his endeavors that the physicians are the pathways to creating more fair pricing and better value. So at this point, I'm not concerned that our capacity is so constrained that it's going to create demand that outpaces supply, and then that's going to lead to inflation even more.
You know, and that particular hospital was here from Indiana, where we do have a lot of physician groups that are part of hospitals and health systems, as I mentioned earlier. You know, what we've seen and what I hope and what we've seen in other states, and I hope we can bring here, is having these independent physician groups that can steer to hospitals that are of high quality, because you've noted high quality facilities and high quality providers. So we have a few other questions here. How do you feel about the NCQA indicators as measures of medical quality of health provider groups?
I would say that I think they're fine. So the NCQA measures are what I would consider to be broad measures that would fall more into the lines of quality assurance, not really exemplifying optimal quality. And so if you go back to, so you have kind of structure measures, process measures, and then outcomes measures. And I think as plan sponsors and consumers, if we have providers that can deliver optimal outcomes, which ultimately could be more sophisticated than just looking at things like, you know, mortality complications, unanticipated encounters, they could be ambulation, you know, quality of life, other more, let's say, comprehensive measures. What I find is many of the NCQA measures or HEDIS measures represent an aggregate or broad measures of performance, but they're not specific enough at the point of a particular procedure or diagnosis where I might want to make a decision. I was also going to make another comment, Gloria, that kind of piggybacks on what you're saying. One of the things that this also does is that there are many providers that work at, that perform services at hospitals that you might be considered average, or they don't have the same brand equity that others do, that might be more willing to give a fair price for the incremental volume and market share. So by connecting physicians and settings of care differently, you actually are going to increase options and availability for services, not constrain them. So I would say NCQA, HEDIS, joint commission measures tend to be very broad, that you're going to want measures that are more specific to the particular need, whether it's a surgery or a disease state that you're dealing with.
Right. And how many measures, quality measures on different service lines you have? Is it 40?
So right now we have 39, but we are about to release outpatient quality that assesses somewhere in the neighborhood of 200 million encounters annually. And we'll look at things like colonoscopies, endoscopic procedures, things that are always performed in the outpatient. And then for those of you that are unaware, CMS recently announced that they were going to be moving about 300 procedures off of the inpatient only list into the outpatient setting, which is going to foster more competition, and those procedures will now be migrating to lower cost settings, which should help you as plan sponsors and members. So in the new world that will be taking place in the next couple months, we'll have many more areas where you can measure very specific performance for physicians and for hospitals or outpatient centers.
Excellent. So we have one other question, and that we have time for, and I appreciate all the other questions that are coming in. This is really interesting about direct primary care physicians. So do you look at the quality measurement in your in your processes? How can direct primary care physicians be involved in this process, because they really want to partner in this space?
So we're actually working with a broker local to the Indy area around wrapping primary care with this information. They use direct primary care in multiple communities in southern Indiana, and as a way for direct primary care to make higher value referrals. And this can be done in any number of ways. And in a passive way, it could be connecting the, let's say, information about RAND and the quality of specific specialists together. This can also be manifest in direct contracting for bundles of care or for specific procedures. But direct primary care is a wonderful way to take this information and bake it into the workflow for the plan sponsor and the plan member. The other thing about direct primary care that's I think that is really wonderful is that they're a trusted advisor to the member in many respects, and they've got a line of sight to the chronic disease management and kind of the underlying illness attributes of the patient. And so we've worked with direct primary care vendors in the past, and we continue to see the interest increase there.
Super. Thank you again for your time. I look forward to continuing to partner with you as we develop publicly available value reports that will include both quality transparency and price transparency. Thanks, Shane.
Thank you. Thanks, Gloria.